So let's go through the pelvis and the hip. Let's start with radiographic views of the pelvis. Here we see the standard AP pelvis view on the left as well as a zoomed in image on the right of the hip. There are a couple of views that are less common, but I wanted to include them for you to be aware of some of the alternate pelvic imaging examples and their indications. One is the inlet view and the other is the outlet view. The inlet view clearly shows the pelvic rim. Additionally, it's ideal to assess for anterior, posterior displacement of any part of the pelvis. Pubic rami fractures are the most common to view here, which could not be seen in the AP view alone. The outlet view shows the SI joint well, but it's best indicated for evaluation of any vertical displacement of the hemipelvis relative to the other side. Finally, the frog leg view with the hip inflection, abduction, and external rotation, its position may be difficult for patients, especially trauma patients, to do. This view is used primarily for the pediatric or adolescent population to assess for slipped capital femoral epiphyses, where there's a displacement affecting the epiphyseal plates. This occurs most commonly during the rapid growth phases, ages 12 to 16 in boys or 10 to 14 in girls, with obese males at the greatest risk. Here we see a 13-year-old male patient. The slipped capital femoral epiphyses is not seen on the AP view, but can be seen in this frog lateral view as noted by the arrow. Now let's go through some basic anatomy. This should be review. We've got the acetabulum, we've got our obturator foramen, symphysis pubis, we've got our superior ramus, in our inferior ramus, we have the ischial tuberosity, iliac crest, iliac fossa. We have our ASIS, or anterior superior iliac spine, and then just below it, anterior inferior iliac spine, and then the sacrum with the coccyx at the end of it. And then onto the femur, we can see the head and neck. Then we have the greater trochanter and the lesser trochanter. Additionally, you can see in yellow the line that represents the posterior rim of the acetabulum, and that is part of the ischium. And in green, you can see the anterior rim of the acetabulum, which is part of the pubis. The acetabular socket is oriented more anteriorly, so your legs can move forward in a flexion position with a greater range of motion than it can backward. So the anterior border will be more medial than the posterior border. Here's an image you can use to test yourself with the features. So let's review the muscles attached to the pelvis. On board exams, you're more likely to be asked about the muscle attachment more so than the feature alone. I will test you on both. You'll have to identify a structure, for example, an avulsion fracture. You will need to identify not only the structure, but the muscle that would be attached at that location. Starting with the iliopsoas muscle, with the fusion of two muscles, the psoas major and the iliacus, to a single insertion point on the lesser trochanter. This is the main flexor of the hip, with a little help from the rectus femoris that originates from the anterior inferior iliac spine as well as the acetabular rim. The sartorius originates from the ASIS to attach to the medial tibia, so it both flexes at the hip and knee while also externally rotating. Moving down to muscle attachments to the greater trochanter on the proximal femur, starting out with the gluteus medius and minimus muscles. These function to abduct the thigh and internally rotate. The remainder of the muscles will be external rotators. We've got piriformis, the superior and inferior gemellus, quadratus femoris, which not only externally rotates but adducts as well. Obturator internus not only externally rotates but also helps with abduction with its position up and over the neck of the femur. And the obturator externus that just externally rotates. Muscles of adduction are going to be found medially. The superficial layer begins with pectineus. It goes along the pectineal line. Additional radiographic lines will be discussed shortly. the adductor longus that originates from the body of the pubis just below the crest. Inferior to the longus insertion is the insertion for abductor brevis from the inferior ramus, and most medially, gracilis. Here is a summary image of regions that you can find avulsion fractures from, along with their associated muscular attachment that would be involved to help you understand how a patient may present with that specific injury. Here's a beautifully annotated image from one of my favorite radiology sources, The Radiologist. I believe his content is on Instagram. Let's now check the pelvic lines for continuity from this radiograph. We're going to see the pelvic ring as a whole, and we can look at the obturator foramen. The iliopectineal line identified by arrows is the portion of the pelvic rim from the sacroiliac joint along the medial border of the iliac wing to the superior border of the pubic bone to the symphysis pubis. Disruption of this line represents an anterior column fracture, which is a real specific name that you don't really need to know, but it's just referencing an acetabular fracture, obviously on the anterior side. This rim also can be displaced with a superior pubic ramus fracture. This is an example showing a 70-year-old male that suffered from a fall on his right side. We can see the disruption of the iliopectineal line indicating the anterior column fracture. Now we're moving on to the arrows pointing to the ilioischial line. The disruption of this line is going to be a problem with the posterior column fracture affecting the posterior aspect of the acetabulum. We can see in this same patient that he also has a posterior column fracture indicated by his altered ilioischial line. Now this cup shows a nice acetabular roof. This line falls along the anterior border of the acetabulum, while this line falls along the posterior border of the acetabulum. Here's our same patient again. This shows that he has signs where there's some damage to the roof of the acetabulum. This is Shenton's line. This goes from the inferior border of the superior ramus to the inferior-medial border of the femoral neck. Disruption of this line could indicate a dislocation of the hip or fracture of the femoral neck, although it's important to note that there can be a femoral neck fracture that doesn't alter this line, which is the point of being sure to get additional views if that is suspected and not apparent in this AP view. Now, a nice summary image with all of these. I should mention the yellow teardrop reference is referring to the acetabular wall. This is used as a reference point for a number of conditions like fracture displacement or acetabular migration. Here's an example where the pink arrow indicates disruption in the iliopectineal line on the right side. The blue, black, and red arrows on the left side of the patient are indicating normal lines. The white arrow indicates the ilioischial line has shifted away from the teardrop shape. In red, this indicates there's a fracture displacement. Again, an image from my favorite social media radiologist, and yet another one. Now let's look at some proximal femur fractures. Fractures of the femur are categorized into intracapsular within the hip joint or extracapsular. Can you see where the fracture is? This is known as an intertrochanteric fracture. Can you see it now? Here is another patient where we have likely an elderly female that has fallen and has pain in her left hip. Do you see the fracture? It's undisplaced, so it's a bit subtle. Let's look at another view. Here's the fracture. It's located in the neck of the femur. The cool thing about this case is that we have imaging after she was taken to surgery for repair with a dynamic hip screw. Here's an example of a left femoral head fracture. See the nice round head of the undamaged right femur? Well, this really highlights the region of damage on the left femur in this patient. Finally, here's an anatomy reminder of the vascular supply to this region, which can be dramatically affected if the fracture is displaced. The greater the displacement, the greater the risk of vascular disruption. The medial circumflex artery off the femoral artery is the most predominant blood supply to the head of the femur. There's also a small minor artery directly to the head called the foveal artery, which comes off the obturator artery. Okay, in summary, here's a list of the structures that we went through. Here are some muscles. listed, you should know their attachments and their actions. And the radiographic lines, these are general lines. I will probably show imaging that shows any one of these are disrupted and ask you to identify the line or the indication of what bony structure might be affected or what muscle attachment to that. So these would be some examples to study by.